Clinical definition of dementia. Dementia is defined as the global deterioration of higher mental functions. It is clinically characterized by severe problems with memory and at least one other cognitive domain. Other cognitive domain involves learning and reasoning, language, spatial ability, handling complex tasks. So learning means being able to acquire new skills, or reasoning like calculation problems, language impairment in word finding, syntax or global expressions, or the receptive speech. Then other problems like spatial ability, getting lost in the familiar neighborhoods, handling complex tasks like inability to manage personal finances, cooking complex meals, or driving. Now we have a crucial marker. These deficits must be severe enough to directly interfere with the daily activities, that is ADL, activities of daily living. Now what are the common causes of dementia? Clinically categorization is split by neurological repression, metabolic depression, and the hospital care. When there is no additional neurologic deficiency, we have two conditions like Alzheimer's disease and the frontotemporal dementia, which is also known as the PIC disease. Then, with additional neurological deficiency, we have multiple infarct or the vascular dementia, Parkinson's disease, Wilson disease, chronic infection. Chronic infections include tuberculosis, fungal infections, HIV, AIDS, progressive multifocal leukoencephalopathy, that is PML, and neurosyphilis. Then we have the hydrocephalus, which is obstructive and non-obstructive. Then we have the normal pressure hydrocephalus, that is NPH. Then we have chronic subdural hematoma, SDH, Lewy body dementia, brain neoplasms or the tumors. So these are the conditions with additional neurological deficiency, and only two conditions where there is no additional neurological deficiency are the Alzheimer's disease and the PIC disease, that is frontotemporal dementia. Other metabolic disorders causing dementia are dialysis dementia, hypothyroidism, hyperparathyroidism, uremia, hepatic encephalopathy, porphyria, vitamin B12 deficiency, adrenal insufficiency, Cushing syndrome, chronic hypoglycemia. Other toxic causes like heavy metal poisoning, chronic substance abuse like alcohol encephalopathy. So these are the causes of the dementia. Now, there is one example that hypothyroidism, vitamin B12 deficiency, MPH, and the chronic subdural hematoma are highly because they represent the reversible causes of dementia if diagnosed and treated early. Now, what are the clinical features and what is a disease progression? So, there is one precursor stage before the initial stages, which is known as mild cognitive impairment, where there is memory complaints like crucials to be qualified by an informant. Then we have the impairment level, where memory deterioration relative to the patient age and education background. Then we have the preserved assets, like general cognitive function is preserved and activities of daily living remain. So this is the mild cognitive impairment. However, the daily activities remain fully intact. And then we have the MMSE range, where generally which score between 26 to 28 on the MMSE examination, that is Mini Mental State Examination, and according to MCI, serve as a precursor state to multiple dementias including Alzheimer's, Parkinson's disease, Lewy body, vascular, neoplastic, NPH, and the metabolic-induced dementia. Now, what is the chronological progression of the symptoms? So, there is stage 1, where there is early lapses, there is memory lapse, reasoning and judgment impairment, mood alternation like sadness, anger, frustration. These are highly common in the early stages of dementia. Therefore, this stage is also known as early lapses. Then we have stage 2, where there is gradual decline. There is deficits in all higher mental functions. There is onset of dysphagia, apraxia, agnosia, urinary incontinence, and the focal neurological deficits. And then there is a stage 3, which is a later stage where there is deterioration in the personality, hygiene, self-care. The patient becomes completely dependent on others for basic survivals. And then we have a stage 4, that is advanced stage, where patient become mute, remain bedridden, and ultimately succumb to intercurrent infections. Now, what are the diagnoses? So we have certain diagnostic investigations and imaging workup. A comprehensive clinical evaluation must cover serology, imaging, and functional testing to pinpoint the etiology. So what are the serology and fluids? So we have LFTs, RFTs, endocrine evaluation, B12 estimation, VDRLs, HIV testing, and CSF analysis. These are the serology and fluid tests. LFT excluded the hepatic encephalopathy, renal function test screen for uremia, endocrine evaluation rule out the thyroid and parathyroid pathology and adrenal insufficiency related to dementia. And then we have serum B12 estimation, which excluded the subacute combined degeneration. Then we have the VDRL. This test is compulsory screen for neurosyphilis. Then we have HIV testing to direct the viral encephalopathy screen, and then we have the CSF, cerebrospinal fluid analysis, which rule out the chronic meningitis, that is tuberculosis or the fungals or the PML biomarkers. Then we have neuroimaging and the electroencephalography, that is EEG. This assesses the subclinical epileptiform activity or the metabolic encephalopathy patterns. Then we have the CT scan that identify the structural lesions, subpleural hematomas or the hydrosperms. Then we have the MRIs, which evaluate the hippocampal atrophy patterns, such as in Alzheimer's disease, which is not associated with the chronic stages of the neurodegenerative disorders. And then we have the chronic white matter ischemic loops. So these are done with the help of MRI. These are checked with the help of MRI. Then we have the PET scan, that is positron emission tomography, which highlights the regional hypometabolism, that is temporoparietal in ADs versus frontotemporals in pig disease. Then we have the clinical treatment protocols, which is a gold standard rule. So what is the clinical treatment protocols? So we have to treat the underlying cause wherever possible. For example, surgical evacuation for the chronic subdural hematoma is performed. BP shunting for normal pressure hydrocephalus, that is NPH. Vitamin B12 replacement injection for deficiencies, thyroid hormone therapy, levothyroxine for clinical hypothyroidism, specific antimicrobial or antiviral treatment for neurosyphilis, tuberculosis or HIV related dementia. This is all about dementia.